All right, so we're going to talk about bipolar and related disorders. This is a group of disorders that has been seen to increase. And so it is important that we make sure that we fully understand the symptomology for these. So in terms of bipolar 1, we're going to talk about this first. Bipolar 1 is when a client has at least one manic episode. They don't need to have a depressive episode, but they must meet criteria for at least one manic episode. So the manic episode is, we take a look at this baseline. You can look at euthymia. So there's a baseline, but a manic episode has a really high low, or a really high feeling of being on top of the world. And so this manic episode can't be better explained by any of the disorders in the schizophrenia spectrum or by any other psychotic disorders. In regards to the number of symptoms, the client needs to have experienced 3 out of the 7 of the symptoms for 1 full week, or if their underlying mood is irritability, then they need to have experienced 4 out of the 7 of the symptoms. Or option 3 is that there has been a hospitalization due to the manic episode. So there's kind of three different scenarios here. One is 3 out of the 7 symptoms for 1 week. 2 is, they have an underlying mood of irritability. Therefore, they have to have 4 out of the 7 symptoms, or there's a hospitalization involved. So I like this DIGFAST acronym. I actually got it from Dirty Medicine, which there are some that I'll have you be watching. Some videos that the individual does. So, but anyways, the DIGFAST acronym helps to, is a nice mnemonic to remember the symptoms. So distractibility, impulsivity, grandiosity, this flight of ideas, just the going by really fast, high activity level, energy level, a decreased need for sleep, which means often that they are doing activities instead of sleeping. They have these large aspirations and plans to do things. And then T is for talkativeness. So their speech, how rapid is it? How loud is it? How close are they to you in terms of speaking, and how pressured is it? So again, great acronym to help you remember the symptomologies or the symptoms of this. So bipolar 1, let's take a look at manic, hypomanic, and major depressive, the different episodes that can be seen in bipolar 1. Again, just remember the manic episode is required. So they may currently be in a hypomanic episode, but they have to have some experience within their lifetime of a manic episode. So again, at least 1 full week of symptoms, mostly every day. And we talked about the number of symptoms. A hypomanic state is, or episode is, they don't reach this really high, but it is definitely an elevated mood from euthymia, as well as the duration of the symptoms when they're presented. So a hypomanic episode is that they have experienced these symptoms for 4 consecutive days. And then same in terms of the number of symptoms. And then in terms of major depressive episode, again, not required, but this is when a client or a person experiences 5 or more of the symptoms for at least 2 weeks. And again, they're experiencing the symptoms most of the day, nearly every day. At least one of the symptoms has to be a loss of interest or depressed mood. And then the other four, the other four symptoms can be what's listed on 141. So let's talk a little bit more in terms of in terms of severities and specifiers. So severity, there's been a slight change in terms of the DSM-5 text revised. They discussed the changes in particularly as it relates to the manic, if the current episode is a manic episode. So mild is, few symptoms result in, a minor impairment, or if it's a current manic episode, there's minimal symptoms that are met. Moderate severity is there's a significant increase in activity or impairment in judgment, a significant number of symptoms that are met. And then severe is that it is unmanageable. The symptoms are unmanageable. They're very distressing. And again, they also added in the text revised that in terms of a current episode of mania, there needs to be consistent supervision in order to prevent the person from hurting themselves or hurting others. When we look at specifiers, there are a lot of specifiers. I didn't list all of them, so please make sure that you take a look at your DSM and read through all of the different specifiers. But a couple that I wanted to mention have to do with remission. So partial remission means that it's been less than 2 months with no symptoms, or the current symptoms don't fully meet criteria for an episode. Full remission is that they have experienced no symptoms for 2 or more months. And then, sometimes we'll see rapid cycling. And so that's at least 4 episodes, 4 mood episodes, whether it's manic, hypomanic, or depressive within the last 2 months or within the last 12 months. When we are taking a look at recording, we're going to list the diagnosis. We're going to identify the current episode that they are experiencing. We're going to identify the severity, so mild, moderate, severe. If there's any psychotic or remission specifiers, as well as then any other specifiers after that. So I gave an example there for you to take a look at. All right, so I just wanted to give some ICD-10 numbers for you in terms of severity with psychotic features and remission, as well as what the current episode is, if it's manic, depressed, or hypomanic. In terms of considerations for bipolar 1, we do have to pay attention for suicide. So clients are, they can be very, very impulsive and unable to stop themselves from hurting themselves, which is also why in the severity, if we are looking at severe, we may be looking at hospitalization to help prevent that from them hurting themselves. Women tend to experience rapid cycling more than men. There is an onset that is usually around 18. However, something to be mindful of is culture, and that people who, or cultures that place a higher value on individualism tend to have a family history of mental health, as well as tend to be a little younger in terms of the symptomology beginning, the onset. We might also see a family history being more common in high-income families, as well as those in the US versus Europe. So I identified some differential diagnoses that we could take a look at. These are listed in the DSM, but I kind of gave some quick identifiers in terms of how they are different from some of these other diagnoses. And also in terms, I provided a list of some co-occurring disorders that we might often see with someone who has bipolar 1. Bipolar 2. So as you can tell from the diagram, so the hypomania or hypomanic episode is not as elevated as if they were experiencing a manic episode. So in bipolar 2, they do have to experience a major depressive disorder. So that's different than the bipolar 1. So bipolar 2 has the major depressive disorder as well as a hypomanic. So, and again, they don't reach, for bipolar 2, they don't reach the full 7 days for duration of symptomology, because if they do, then it's automatically bipolar 1. So in terms of, any other differences, I kind of talked about this in the bipolar 1 discussion. So oftentimes we see a client initially presenting in a manic depressive episode. And then as we go through and talk with them, they provide more information in regards to symptoms that would be met for a hypomanic episode. And the recording for the diagnosis is the same as it was for bipolar 1. Considerations. So the average age of onset is in the mid-20s. The common symptom that we often see is impulsivity. And in regards to a differential diagnosis, the cyclothymic disorder is something that we want to rule out. And so I'll talk a little bit more about that coming up here, but they don't meet the symptom or duration criteria for bipolar 2, but they do have manic and depressive symptoms. So they kind of go up and down, up like a little roller coaster. And then a common co-occurring disorders that we often see is anxiety and or substance use. Okay, so as I mentioned just a minute ago, the cyclothymic disorder is that rapid cycling of highs and lows, but not significantly high and not significantly low. We see that in terms of duration, they've been experiencing this kind of pattern of ups and downs for 2 years. If the individual is a child or adolescent, then it needs to be 1 year. Symptoms are present most of the time, and there has not been a time of more than 2 months that they have had no symptoms. And as I mentioned, they don't meet full criteria for the manic or major depressive. They're just kind of in this like up and down roller coaster. Considerations, as I mentioned, onset can be as early as adolescence, and it's that fluctuating mood. Something to rule out and make a referral for is taking a look at any thyroid problems. This can often present itself similar to these ups and downs. So do make sure that you refer for blood work by the primary care provider, the PCP, so that can be ruled out. Co-occurring disorders could be substance use or substance-related disorders, as well as sleep disorders. All right, substance or medication-induced bipolar and related disorders. So we might see somebody presenting with symptoms that are concurrent with bipolar and related disorders. However, it is impacted by a substance that the individual is taking in or putting into their body. So there may be elevation in mood. There may be irritability with their mood. But again, it's in relation to a substance or medication that the individual is taking. There is some specifiers that we'll talk about in terms of if the symptoms occur, whether while the individual is intoxicated, if they're withdrawing from the substance, or if they're currently not ingesting or putting the substance into their body, but yet they are still having these symptoms. Okay. So there are more substances, obviously, than just alcohol and cocaine. I just listed these here, but please take a look at your DSM because there are several others that are noted for that. And so again, it just depends. Also, we would be taking a look at specifiers in relation to the severity and the use. In terms of how we actually write this out, we would, it depends on if the criteria is met for a substance use disorder as well. So if the criteria is not met for an additional substance use disorder, then we only put the bipolar and related disorder noted. So as you can see in that first bullet point, we would just put cocaine-induced bipolar and related disorder with onset during withdrawal. Now, if the client does have a substance meets criteria for a substance use disorder, then we would identify that substance use disorder first, followed by the fact that substance induces the bipolar and related disorder. Okay, so as you can see listed below, the second bullet point shows how we would write that out. So moderate cocaine use disorder with cocaine-induced bipolar and related disorder with onset during withdrawal. Sometimes we might see, as I mentioned, we might see some of these symptoms as they relate to another medical issue. It's important for our clients to make sure that they are having an annual exam, annual blood work to help rule out or identify any other medical issues that may be going on. It's a way of providing holistic care and making sure that we are doing our due diligence and really making sure that the diagnosis is accurate and correct. That's part of our ethical guidelines. So I listed a couple that could be other medical conditions that might mimic some of the symptoms of a bipolar and related disorder. So hypothyroidism, as well as multiple sclerosis. Then we take a look at other specified, unspecified bipolar and related disorders. So we've kind of gone through this before in regards to the difference of those. A new one is unspecified mood disorder. So basically that's when we can't really say unspecified bipolar related disorder or unspecified depressive disorder. We're so unsure about which one would be the correct one, the correct diagnosis. And so instead of putting both of those, then we would just put unspecified mood disorder. If you have any questions about bipolar and related disorders, please make sure that you reach out to me. I'm happy to help.